Assalamu alaikum dear students, welcome to Dr. Rumi Lectures. Today we are going to discuss blood physiology UQs from past papers of UHS. Our very first question is, list and briefly explain the functions of plasma proteins. Plasma proteins are albumin, globulins and fibrinogen. Some important functions of plasma proteins are that they exert osmotic pressure, which is also called as oncotic pressure or plasma colloidal osmotic pressure. This pressure distributes water between blood and interstitial fluid. Albumin is the most abundant plasma protein which exerts two-thirds of the total oncotic pressure. In those conditions in which plasma proteins are deficient, for example in liver failure, in nephrotic syndrome and in kwashiorkor, there will be less oncotic pressure, fluid will ooze out of capillaries and it will accumulate in the interstitial spaces, hence causing edema. Plasma proteins also import the important function of transport. For example, albumin transports bilirubin, calcium, fatty acids, steroids, and some drugs. Thyroxine binding globulin is an alpha 1 globulin which transports thyroid hormones T3 and T4. Ceruloplasmin is an alpha 2 globulin which transports copper. Some beta globulins are also transport proteins, for example, lipoproteins which transport lipids, steroids, and cholesterol. Transferrin transports iron. Plasma proteins are also for blood clotting. Fibrinogen, which is clotting factor 1, prothrombin, which is clotting factor 2, clotting factor number 5, 7, 8, 9, 10, 11, and 12 are all plasma proteins and they take part in the blood clotting. It is important to note that clotting factors 2, 7, 9, and 10 are vitamin K dependent clotting factors and they are synthesized in liver. Gamma globulins are also called as immunoglobulins or antibodies. They are very important to resist against infections. At 7.4 pH, our plasma proteins are negatively charged. Hence, they can bind with hydrogen ions and they are important in buffering the blood pH. One-sixth of the total buffering capacity of our plasma is because of plasma proteins. Plasma proteins are also precursors of important blood substances. For example, angiotensinogen protein, when activated, it makes angiotensin. Angiotensin causes vasoconstriction and hence it increases blood pressure. Plasma protein also contributes to the viscosity of blood. The viscosity of plasma, which is because of plasma proteins, is 1.5 times that of plasma. Viscosity increases the resistance and hence it increases blood pressure. Some plasma proteins also play their role in inflammation. For example, complement proteins, acute phase proteins, for example, C-reactive protein, CRP, fibrinogen, and haptoglobin. Next question is, draw a diagram to explain the stages of erythropoiesis. Erythropoiesis means production of new red blood cells which takes place in red bone marrow. The first stage of erythropoiesis is proerythroblast, which is also called as megaloblast. Its diameter is about 20 micrometers. It has a large nucleus with fine diffuse chromatin and very prominent nuclei. Hemoglobin production starts in the cell. Proerythroblast divides to make basophil erythroblast, which is also called as early normoblast. Diameter of the cell is about 15 micrometers. In this cell, nuclei disappear. It is called as basophil erythroblast because its cytoplasm contains a lot of rough endoplasmic reticulum and ribosomes which contain ribonucleic acid and that stains with basic dyes. That's why this is called as basophilic cell. Basophil erythroblast differentiates into polychromatophil erythroblast, also called as intermediate normoblast. Its diameter is 10 to 12 micrometer. Its nuclear chromatin further condenses. Hemoglobin starts appearing in the cell and that takes acidic dyes. So it also has some pink color and it also stains with basophilic dyes. So that's why this is called as polychromatophil erythroblast. Next cell is orthochromatic erythroblast, which is also called as late normoblast. It has a diameter of about 8 to 10 micrometer. Its nucleus condenses and becomes very small in size. This is called as pycnosis. Its nucleus will be disintegrated or excluded out of cell so that it provides more room for packing more and more hemoglobin. Next cell is reticulocyte, which is immature red blood cell. Its diameter is about 8 micrometer. It has reticulum of the membranes of mitochondria and endoplasmic reticulum. Reticulocyte is the cell which enters from bone marrow into our bloodstream, and within 1 to 2 days it matures into erythrocyte, which is mature red blood cell. The percentage of reticulocyte in our circulation is just 1 to 2%. However, in case of rapid erythropoiesis, the percentage of reticulocyte increases. The mature reticulocyte is 7.8 micrometer in diameter. It has no nucleus, no organelles, so that it can pack a lot of hemoglobin. And its shape is like a biconcave disc. So you may be asked to draw and label the stages of erythropoiesis or to explain all the stages with the features of all the cells. Next question is name the cells that secrete erythropoietin. What controls its secretion? Erythropoietin is a glycoprotein hormone. 90% of this hormone is produced from kidney, 10% from liver. Erythropoietin hormone is secreted from the fibroblast-like interstitial cells which are present around the nephrons in the cortex and outer medulla of kidneys. It is also believed to be produced from the peritubular capillaries and also from the tubular cells of the nephron of kidneys. Hypoxia or low oxygen carrying capacity of blood is the most important stimulus for the secretion of erythropoietin hormone. All those factors which decrease tissue oxygenation, for example, low blood volume, anemia, having low hemoglobin, poor blood flow as in case of cardiac failure, pulmonary disease as in case of emphysema, and living at high altitude, all these conditions decrease the oxygenation of tissues, and kidneys and liver increase the production of erythropoietin hormone, which stimulates our red bone marrow to increase the speed of erythropoiesis, and hence the production of red blood cells increases, which increases the oxygen carrying capacity of blood. Next question is explain why people who do not have adequate quantities of transferrin in their blood tend to develop severe hypochromic anemia in relation to iron metabolism. Transferrin is the transport protein that carries iron in our plasma. It transports the absorbed iron from the intestines to the tissues, and also it transports the stored iron which is required to be mobilized to those tissues where it is needed. Let's suppose we have to transport iron from its stores to the bone marrow for erythropoiesis. The stored form of iron is ferritin, which provides iron. That iron binds with transferrin and it goes to bone marrow. However, if transferrin is deficient, then bone marrow will not get iron. In normal cases, when iron binds with apotransferrin, it makes a complex which is called as transferrin. This transferrin protein is ingested by the erythroblasts. Erythroblasts in the bone marrow have the receptors for transferrin. When transferrin binds with its receptors on the erythroblasts, it is ingested along with its iron. Iron is delivered to mitochondria where heme synthesis takes place. However, if someone is deficient in transferrin, this iron transport to the erythroblasts of the bone marrow cannot take place, and these people will have very less hemoglobin in their red blood cells, which means these red blood cells will be hypochromic, and such a person will develop severe hypochromic anemia. Next question is a young woman is having iron deficiency anemia. What changes occur in her hemoglobin concentration, red blood cell count, mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration? Iron deficiency anemia is more common in females, and because of deficiency of iron, there will be less synthesis of hemoglobin, so hemoglobin level will be low. The other parameters, red blood cell count, mean corpuscular volume, and mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration will also be low. Normal mean corpuscular volume is between 80 to 100 femtoliters. In this case, it will be less than 80 femtoliters, which means the cells will be smaller in size and also pale in color. So that's why iron deficiency anemia is microcytic hypochromic anemia. Next question is Mr. Ali goes to a hilly area at an altitude of 10,000 feet. What will be the effect on erythropoiesis? Explain the mechanism of this effect. When someone moves from sea level, for example from Karachi to a hilly area which is at high altitude, he is faced with low oxygen content in the environment. This hypoxia decreases the oxygenation of tissues, and kidneys start producing more and more erythropoietin hormone, which stimulates bone marrow to increase the production of red blood cells. This is why those who are living at high altitude have a higher count of red blood cells than those who are living at the sea level. In native dwellers at high altitude, this is called as physiological polycythemia. The count of red blood cells and hemoglobin content is increased so that the oxygen carrying capacity of blood can also be increased. Next question is name various granulocytes and agranulocytes. There are two types of white blood cells. Agranulocytes are those white blood cells in the cytoplasm of which we cannot see prominent granules under light microscope. And these cells are lymphocytes and monocytes. Granulocyte contains prominent granules which are visible under light microscope. And these are neutrophils, basophils, and eosinophils. By the way, which cells are important for acute bacterial infections? These are neutrophils. Which are the most abundant white blood cells? These are neutrophils. Which cells are increased in allergic reactions? These are Basophils. Which cells release histamine and heparin? These are basophils in the blood and mast cells in the tissues. Which cells are important for parasitic infestations? These are eosinophils. What is the name of largest white blood cell in peripheral circulation? This is monocyte. And which white blood cell is most important for immunity and is second most numerous white blood cell? And this contain a round nucleus which almost completely fills the cytoplasm. The answer is lymphocyte. According to Guyton physiology, the average percentage of neutrophils is about 60%. For lymphocytes, it is about 30%. Monocytes are about 5%, eosinophils about 2%, and basophils are less than 1% in your peripheral circulation. This relative percentage of different white blood cells is called as differential leukocyte count or DLC. Next question is, what is the walling off effect of inflammation? One of the important feature of inflammation is that when inflammation is occurring, for example, in response to infection, there will be walling off of the injured area from the remaining tissue. And this is done by clots which are made of fibrinogen. It prevents the flow of fluid in the tissue spaces and hence it delays or prevents the spread of bacteria in the tissue spaces. This walling off effect is directly proportional to the local tissue injury. For example, Staphylococcus bacteria releases more damaging toxins in our tissues. So this is why this is rapidly walled off as compared to Streptococcus. Because Streptococcus causes slow tissue destruction and it is slowly walled off. So this is why Streptococcus, because it is slowly walled off as compared to Streptococcus, it has a more tendency to spread through our tissues. Next question is, summarize the 4 lines of body defense system during inflammation. This question can also be asked in another way. Summarize the macrophage and neutrophil responses in chronological order in inflammation. The first line of defense against infection during inflammation is those macrophages which are already present in our tissues. And if these macrophages were sessile or immobile, they become detached from their sites of attachment, they become enlarged rapidly and become more active. Although they are not great in number, but still they defend against infection and they are life saving. The inflamed area is invaded by neutrophils, which are second line of defense. Neutrophils are those white blood cells which are already activated in our blood, they need not to be activated. Some important biochemical mediators which attract neutrophils in the site of inflammation are inflammatory cytokines, for example, interleukin 1 and tumor necrosis factor. And then the monocytes from blood also start entering the inflamed tissue, and this provides the third line of defense. The percentage of monocytes in our blood circulation is much less as compared to neutrophils. Average percentage of neutrophils is about 60%, but for monocytes it's about 5% of the total white blood cells. And also when these monocytes enter into the tissues, they need to be activated to become macrophages and it takes several hours to be activated. However, when macrophages are formed from monocytes into the tissues, these macrophages can phagocytose much more bacteria as compared to neutrophils and also larger size of the necrotic materials from the inflamed tissues. Increased production of the granulocytes and monocytes from the bone marrow is fourth line of defense against inflammation. From the inflamed tissue, there is release of different mediators, for example, granulocyte, monocyte, colony-stimulating factor, granulocyte colony-stimulating factor, and monocyte colony-stimulating factors. All these growth factors act on the bone marrow, and 3 to 4 days after infection, bone marrow starts producing and releasing more and more granulocytes and monocytes into the blood circulation, which then enter into the circulation. If there is a continuous stimulus from the inflamed tissue, the rate of production of granulocyte and monocytes from the bone marrow can be at a much faster speed of maybe up to 20 to 50 times normal, and they can provide granulocytes and monocytes for many months and years. Next question is, describe the features and functions of reticuloendothelial system. This system is also called as monocyte macrophage system or mononuclear phagocyte system. This system is made of macrophages. In different organs, these macrophages are named differently. For example, in liver, these macrophages are called as Kupffer cells. In lungs, these are called as alveolar macrophages. In brain, these are microglia. And in spleen, bone marrow, and lymph nodes, these are called as tissue macrophages. And in bone, these are called as osteoclasts. Some important functions of reticuloendothelial system are that macrophages are phagocytic in nature. They can engulf bacteria, and after breaking them into antigens, these antigens can be presented to lymphocytes. and hence the immune reaction may be stimulated. Macrophages in spleen break down old red blood cells and hence heme is produced. And this heme is converted into bile pigments like bilirubin. Reticuloendothelial system is also important in producing clot promoting factors or procoagulants. And last but not the least, they are also important for storage and circulation of iron. So dear students, so far we have discussed past UQs from the topics of first module. From the topics of second module, we'll discuss the past UQs in another session. Thank you so much for watching this video. See you next time in another video.